Now let us discuss the next topic, that is skeletal muscle relaxants. So those drugs which can produce relaxation of skeletal muscles. So they can be classified in broad terms like peripherally acting skeletal muscle relaxants, or which are directly acting on the skeletal muscles, or which are centrally acting and producing skeletal muscle relaxation. The outcome of this skeletal muscle relaxation is different. If you see peripherally acting, they are purely neuromuscular blockades. That means they blocks the neuromuscular junction, and they are purely skeletal muscle relaxants. They relaxes the muscle up to a level of paralysis. While directly acting and centrally acting skeletal muscle relaxants, they will not produce paralysis, but they will relieve the spasm due to excessive skeletal muscle contraction, and they are usually known as spasmolytic. Let us see what is the difference between a pure skeletal muscle relaxant and a spasmolytic. So spasmolytic and skeletal muscle relaxant. Spasmolytic, they are usually drugs which act either centrally, that is at the level of spinal cord, or directly on the skeletal muscles to relieve the spasm. While neuromuscular blockades or skeletal muscle relaxants, what we call, they are purely NM receptor antagonists. Kindly refer back NM receptor, nicotinic receptor, which is located in the skeletal muscle end plate, a cholinergic receptor, which is responsible for producing skeletal muscle contraction in response to the release of acetylcholine, or acetylcholine will act on NM receptors on the skeletal muscle end plate and produce skeletal muscle contraction. So if the NM receptor is blocked, acetylcholine will no longer be able to produce the contraction of skeletal muscles, or even no longer will be able to maintain the normal tone of the skeletal muscles. So spasmolytic, they make the hypertonic skeletal muscle back to a normal tone. The spasm is due to the disorganized or excessive contraction of muscles. So the excessive contraction is due to hypertonicity, and the hypertonicity can be brought back to a normal tone, and muscle behaves like a normal one without excessive contraction. While skeletal muscle relaxants, they bring about the skeletal muscle tone to zero or nil. So that means the complete tone of the muscle is lost, and the skeletal muscle is no longer able to perform the normal functions too. Like if you see the neck muscles, they are tonically contracted. That's why our head is upright. We are able to maintain a posture. We are able to stand up. We are able to continue standing because many of the skeletal muscles are tonically contracted. But when skeletal muscle relaxants are given, entire tone of the muscle is lost, and it can lead to paralysis of skeletal muscle. Spasmolytic, they never produce paralysis, but skeletal muscle relaxant causes complete paralysis of skeletal muscles. Coming to the uses, spasmolytic, they are mainly used in the spastic conditions associated with the spinal cord injury or cerebral palsies. While skeletal muscle relaxant, they are mainly used in pre-anesthetic medication given before anesthesia or surgeries to facilitate the surgical procedures. Coming to classification, first is skeletal muscle relaxant or neuromuscular blockers, or known as NM receptor blocker or antagonist. Know the term NM receptor antagonist blocks the NM receptor and prevents the action of acetylcholine through the NM receptors. Subclassification, competitive or non-depolarizing blockers. So competitive, they compete with acetylcholine. Non-depolarizing blocker, I'll come to that what it is. The next point. Example, D-tubocuronium or pancuronium, which are long-acting drugs. Second, vicuronium, rocuronium, etracurium, intermediate acting. Etracurium, kindly refer back, is a drug which shows Hoffman elimination, a rare type of biotransformation. Refer back. Mivacurium is a short-acting drug useful in case of intubation procedures because it's a short-acting, useful for very short procedures. Second, depolarizing blocker. That makes the difference. The first one was non-depolarizing blocker, and second one is depolarizing blocker. These are drugs which can activate NM receptors, but it continues to activate without a halt, and the continuous activation of the receptors finally lead to the desensitization of the receptors, leading to loss of activity of the receptor and skeletal muscle relaxation. Example, succinylcholine. It also spells somewhat similar like acetylcholine. So they can bind to the acetylcholine receptor, that is NM receptor, activate it, but it is not removed because there is no enzyme available to remove succinylcholine from the synapse. So it continues to activate the NM receptor, and finally the NM receptor will become desensitized. That means the receptor will no longer respond to any of the stimuli. Second is decamethonium. Centrally acting skeletal muscle relaxants. Classical example, diazepam, baclofen, chlorzoxazone, and thiocolchicoside. All of these drugs act at the level of spinal cord, and they mainly act by facilitating GABA mediated inhibitory neurotransmission. GABA, GABA, gamma aminobutyric acid mediated inhibitory neurotransmission at the level of spinal cord. Directly acting, that's directly act on the skeletal muscle, only one drug, that is Dendrone sodium. So first is competitive or non-depolarizing blocker. Mechanism of action, as I mentioned, it is a pure NM receptor antagonist. So it competes with acetylcholine for the NM receptors in the skeletal muscle end plate and block NM receptor, hence leading to lack of response of NM receptor to the constrictor stimuli, that is to the acetylcholine, leading to skeletal muscle paralysis. While depolarizing blocker, it's a two steps of action. First step, it produces depolarization, that is persistent depolarization or continuous depolarization, that is a phase 1. It combined with the nicotinic receptor, that is NM receptor, depolarized motor endoplate, and because of that depolarization, initially it produces skeletal muscle contraction, but it is disorganized skeletal muscle contraction resulting in muscle fasciculation or twitching. And the persistent depolarization will continue since acetylcholine esterase is not able to remove succinylcholine from the synapse. And this phase 2, second phase, it's a desensitization block. Because of persistent continuous depolarization of NM receptor, the NM receptor will finally fail to respond to any of the stimuli. Like what happens in a excessive voltage comes in a electric line, what called short circuit, somewhat like that. So once short circuit comes and their line fails and no current supply, so somewhat like that. So continuous exposure to succinylcholine will lead to desensitization of the NM receptor, leading to paralysis of skeletal muscle. So let us see what's the difference between these two classes. So competitive is pure NM receptor antagonist, while depolarizing is an NM receptor agonist. And competitive blocker, it causes flaccid paralysis, nothing but without producing contraction, directly the muscle go to a stage of paralysis, relaxation and paralysis. But depolarizing blocker initially produces fasciculation or disorganized contraction of skeletal muscle, followed by paralysis, what we call spastic paralysis. Competitive blocker, the muscles affected at low doses, that means very low doses, it can selectively relax some of the muscles, especially the muscles of eye, that is extraocular muscles. So that's the reason why it is highly useful for ocular surgeries. While depolarizing blocker at low doses, they mainly relaxes the muscles of neck, jaw, pharynx as well as the trunk. So that makes it more useful in case of endotracheal intubation procedures and all. Competitive blocker, they causes release of histamine. Both of them do the same thing, so it should be, both of them should be better to avoid during in case of patients with asthma. Competitive blocker, they can produce significant fall in BP. The first reason is reduced venous return because of skeletal muscle paralysis. The blood flow from the legs back to the heart will be reduced. Second, ganglionic blockade and histamine release both will produce again vasodilatation, leading to fall in BP. While depolarizing blocker, they can cause cardiac arrhythmia. And reason is stimulation of sympathetic ganglia, because it is an agonist. It can also stimulate the NN receptor located in the autonomic ganglia. Coming to the next difference, there is no hyperkalemia associated with a competitive blocker, but depolarizing blocker, there is a risk of hyperkalemia and associated cardiac arrest on overdosage. As I mentioned, competitive blocker, they are useful for ocular surgeries, while depolarizing blockers should be avoided during ocular surgeries because it can increase intraocular pressure. So that has to be avoided, and also in patients with the glaucoma, this drug has to be avoided. The competitive blocker, they can cause post-operative paralysis of ileum or even cause post-operative urinary retention. So that has to be urinary retention, not a matter, but ileum will be paralytic. Refer back, neostigmine is a drug which is used to overcome this particular state. While depolarizing blocker, it increases intragastric pressure, which can lead to regurgitation of the gastric content in the esophagus, which can be fatal in case of anesthesia. Next difference, apnea is very much common with the competitive or non-depolarizing blocker because of paralysis of respiratory muscles like diaphragm, intercostal, internal and external intercostal muscles. While in case of depolarizing blocker, it is observed only in some patients, that is the patients with genetic variability, that is patients with the presence of atypical pseudocholinesterases, where the patient is now the patient is not able to metabolize the drug at a faster rate due to the lack of the usual pseudocholinesterase. Refer back, it is mentioned under factors modifying drug action, kindly refer it. So these are some uses of the skeletal muscle relaxant. As I am mentioning, the competitive blocker, neuromuscular blockers, they are mainly used for thoracic abdominal surgeries, intubation procedures and endoscopies. The preferred is mivacurium. Orthopedic procedures, severe cases of tetanus and status epilepticus, where muscle tone will be very high. Pre-anesthetic medication to produce or to supplement skeletal muscle relaxation. While succinylcholine or mivacurium, why I mentioned mivacurium here, because it is a short-acting drug. Succinylcholine is also a short-acting drug. So they are mainly used for brief procedures, or procedures which are short-lasting, like endotracheal intubation, laryngoscopy, bronchoscopy, esophagoscopy, etc. Correction of fracture and dislocation to avoid convulsions or trauma associated with the electroconvulsive therapy. So this figure shows the presence of a receptor. This is a rare type of receptor, never mentioned anywhere. Rhinodine receptor. This is a receptor which is located in the sarcoplasmic reticulum. And the activation of this receptor, rhinodine receptor, in response to depolarization of the skeletal muscle fibers, it will cause the release of calcium from the sarcoplasmic reticulum. And as you studied, calcium is required for excitation, contraction, coupling, followed by skeletal muscle contraction. So if the rhinodine receptor is blocked, the calcium will not be released from the sarcoplasmic reticulum. As a result, there won't be skeletal muscle contraction in response to the stimuli. So just see the drug, it's a dantrolene sodium, directly acting skeletal muscle relaxant. It inhibits calcium release from the sarcoplasmic reticulum in skeletal muscle. The reason is it inhibits rhinodine receptor. It inhibits rhinodine receptor in the sarcoplasmic reticulum and inhibit excitation, contraction, coupling in the muscle fiber. And they are mainly used for malignant hyperthermia and spastic conditions associated with the spinal cord injury or cerebral palsy. So malignant hyperthermia, it is a condition which there will be a rise in body temperature. There is a sudden rise in body temperature, and the reason for is increased release of calcium and intense muscle spasm. And if the rhinodine receptor can be blocked, the release of calcium can be prevented. As a result, intense muscle spasm will be prevented and rise in body temperature can be also prevented. So Dendrone sodium is highly useful in treating malignant hyperthermia. Coming to centrally acting skeletal muscle relaxant, they mainly act at the level of spinal cord and they promote the GABA mediated inhibitory neurotransmission. You can see here GABA mediated inhibitory neurotransmission. The spasmolytic, baclofen, diazepam, already mentioned, clozoxone or thiocolchicoside, all act by facilitating GABA mediated inhibitory neurotransmission, and they are mainly used for spinal cord injury, stroke, cerebral palsy, etc. They are used as spasmolytic to reduce or prevent the spasm or relieve the muscle spasm associated with the spinal cord injury, stroke and cerebral palsy. Don't mention it is used for spinal cord injury, stroke and cerebral palsy. It is used to relieve muscle spasm associated with the spinal cord injury, stroke and cerebral palsy. Coming to the last topic, drugs acting on autonomic ganglia. There are two types of drugs which can stimulate the autonomic ganglia of both sympathetic and parasympathetic nervous system. They are known as ganglionic stimulant, which can stimulate and which can block. They are known as ganglionic blockers. We give more importance for the blockers. Example, pentolinium and trimethophan. Can you note down this drug, trimethophan? It blocks NN receptor in both the sympathetic and parasympathetic autonomic ganglia and block both sympathetic as well as parasympathetic nervous system. So the outcome of action will depend upon which nervous system supplies predominantly to a particular organ. If you see the classical example, heart, the parasympathetic nervous system is the main innervation. So ganglionic blockade will tend to decrease the parasympathetic activity in the heart. As a result, the outcome will be similar to anticholinergic effect. There will be increase in heart rate. While if you see in case of blood vessels, the tone is mainly maintained by the sympathetic nervous system. So blockade of autonomic ganglia will produce an action similar to the blockade of sympathetic activity, leading to vasodilatation. So the action will depend upon which nervous system predominantly supply or control the action of a particular organ. So that's a outcome of a ganglionic blocker. Thank you very much.